CARDIA is brought to you in part by H.D. Smith Foundation, a private grant-making foundation in Springfield, Illinois. Abraham Lincoln Capital Airport, daily flights to Chicago on United and to Dallas on American Airlines. Online at flyspi.com. Eck, Schaefer and Punk, LLP, and ESP Wealth Management, LLC, specializing in fulfilling all your accounting and wealth management needs. Securities offered through First Global Capital Corporation, member FINRA and SIPC. Investment advisory services offered through First Global Advisors Incorporated. Prairie Heart Institute, nationally recognized, locally committed. Online at prairieheart.com. And viewers like you, thank you.
Hello, welcome to CARDIA, Hearts and Sciences, the program dedicated to the understanding of the human heart. I'm Mark McDonald, your host, and always pleased to welcome our co-host, our Dean of the College of Hearts and Sciences, Dr. Greg Mischel, who not only is the Dean of the College of Hearts and Sciences, but he's also the Executive Medical Director of the Prairie Heart Institute. And Dr. Mischel, thanks for being with us. We're going to talk about a project that you have been working on for about 2 years.
2 years.
You and your colleagues. And our other guest today is Dr. Shailesh Nandish, who is the director of the Chest Pain Network at Prairie Heart Institute at St. John's. And Dr. Nandish, we're going to talk to you soon about another project that's going on. But first, we're always interested in what's new in cardiology here. And we mentioned that Dr. Mischel has been working for 2 years with his team on a new project at Prairie Heart Institute at St. John's. And this is going to be a big deal because you all have done a lot of research and you're about ready to unveil and admit your first patient to a new ICU.
Yes. So St. John's has undergone progressive renovations over the years. It's a very old hospital with a lot of new projects inside. And we have combined our cardiology ICU, our post-op surgery ICU, and our CT and vascular surgery ICU all in one combined unit now. A brand new 14-bed state-of-the-art intensive care unit where we're going to look after all of our sickest heart attack patients, post-operative patients, congestive heart failure patients in a combined unit, brand new state-of-the-art. It really is a gorgeous facility and big. I think when we walked through it, I didn't really realize the scale of it until you actually walk through it. And then the amenities that we've built for not just the patients, but their family members who are oftentimes spending days there. We have lockers and showers and a beautiful new waiting area.
We got a chance recently to have Dr. Mischel and one of his colleagues take us through. Now it's still under construction, but let's take a look. Jen Michaels, brand new. In fact, it's so new it's not even open yet.
No, not quite.
Look at this. It looks like upscale hotel lighting. You're trying to have an effect here, aren't you?
We are. We are trying to raise the bar with our patient care.
Make them feel comfortable. What is the first room that you would walk into here?
This first room is going to be our brand new family waiting room. This is a change from the current waiting room where our patients wait today. We created this in more of an airport style. We were thinking about our future and about millennials and other patient visitors that will be visiting their loved ones in our new ICU. So we thought about having plug-ins, USB ports for charging phones, computers, video equipment that might come in, game stations, those kinds of things.
Now let's walk down as we talk, huh?
We're going to have bench seating along the accent wall here, where we will also have a screen that will serve as a TV.
That would be over here?
It'll be right there. This will have a bench here. We're going to have a TV screen over here where you see the wires. not only for TV, but also for educational and promotional imaging as well. So we're working with Kristen and PHII in order to determine what kind of advertisement and patient education that we can put there as well. We're going to have cafe tables, both tall and short tables. This is going to be a bench here. There will be TVs in both sides of the walls here where the cutouts are, where you see the white cutout.
It almost looks like there's going to be a garden or some kind of an outdoor area there. Will that serve any kind of purpose at all?
We have talked about putting a garden there. We haven't completely planned that all the way yet, but that is in the talks, in the works.
Okay, so this is really, the whole point here is to make this available for a family who, they don't know how long they're going to have to stay here, and they don't know how many hours they may want to be present to get news about their loved one, but they can stay here for a period of time, right? And their needs are met here.
Correct. And families will have access to this area as far as the waiting room 24 hours a day. There's not specific waiting times. We're not going to ask families to leave. Most of the families that are here are worried about their loved ones because they're critically ill or they're in the operating room having heart surgery. So the idea was to make it inviting in a place where the families can gather and wait for news on their loved ones.
Jen, it looks like there's a room here that would be used for consultation or something like that.
That's exactly what that room is for. So for patients that maybe are having an open heart surgery or a surgical procedure, we will call down, we'll let the family know that the surgeon's going to come down and talk to them about how the surgery went, and this will be one of the rooms where those families can have the discussions with their surgeon.
So now we've entered the patient area, right?
Correct, yes.
And just if we get our bearings here, the surgical suites, the patients would come in from that way, and the cath lab patients would come in from that way, but they'd all enter through that double door there.
Correct. This is the patient entrance. So all of the patients coming into the new cardiac ICU will be on stretchers or on beds, so they will all enter through these doors and then they'll go to their assigned room.
Okay, and that's 14 rooms, right?
Yes.
And that's more or less than you presently have in the
That's
hospital?
more than we presently have.
More, okay. And so these rooms are all assigned, and then right in the middle down here, we'll see that there's a nursing station, but actually have more than one nursing station.
We do have more. We have 2 nurses stations.
Just remarkable how brand new everything is, and what this will look like when you actually get it equipped, when you get all the equipment in here.
We're very excited about this new construction project. We'll have 2 different nurses stations. We've built in physician work areas at each nurses station, so the physicians can look at the telemetry, look at test results, labs, patient's chart. You'll also notice as we walk down the hallway in the light blue areas, you'll see some raised countertops. We'll be putting computers at each countertop where the nurse can look in and see his or her patient, and then the blinds can be either open so I can see into the room as a provider, or I could close the blinds for privacy. But I can see my patient and still continue to chart.
Okay, can we go in one of these?
Sure.
How about this one? How about this one here? Okay, so this is one of the 14 ICU units. The patient that would be assigned to this room would either have come out of open heart surgery, more than likely,
Correct.
or come out of the cath lab and needed to stay here for a period of time.
Correct. Or they could be a patient in that comes in through the emergency room or at another hospital that's critically ill as far as cardiac disease or cardiac problems.
And these rooms are bigger than the current ICU unit. These rooms are
These
more
rooms
space,
are bigger than our current cardiac ICU rooms, yes.
What else do they have that you wouldn't presently have?
In our current layout, we do not have ceiling lifts in every room, so that helps.
Is that what this is?
That is what that is. Every room is equipped with a ceiling lift. That way it helps us turn and reposition our patients. There's not as much lifting by the nursing staff. We have computers mounted in every room so that we can easily assess the chart. We have surgical lighting. That way, in case we would need to the physician would need to do a bedside procedure, or if we had an open heart patient that wasn't doing well, we could help the surgeon could do what they needed to do as far as
emergency surgery can be performed in these rooms.
Correct.
Wow, that's I guess that's a necessary thing, but that's kind of scary to think about that a person would be in that kind of condition. But if you don't have time to move them, you got to be able to do it here, right?
Correct.
And then you've got a privacy area over here too.
There is a privacy area over there where the restroom is for the patients.
TV on the wall.
Correct.
TV. And of course, it looks like you've got facilities here to plug in any kind of electronic equipment.
Correct. We can anything from IV pumps to Impellas, Ecos machine. We can fit it in this room.
Yeah.
The other addition that makes these rooms different than our current rooms is the windows. So our current layout, we do not have windows, so there's no outside light.
Yeah.
That was the big advantage to building the new cardiac ICU. So we're going to have sunlight into the rooms. That also helps with the patient condition. Sometimes patients get confused and they're not able to tell the difference between day and night.
Oh, but that's right. Yeah. Yeah. So natural light not only makes you feel better, but it kind of keeps your
It's
circadian
healing.
rhythms going on, doesn't it?
Correct.
Yeah. Terrific. Well, Jen, thank you so much for showing us around.
Yes, thank you.
Dr. Michaelis, this is going to be an immense improvement for the patient care.
Well, just from the space that we have here, I think we're in the order of 15,000 square feet.
Wow.
It allows us to bring together the cardiology patients, the surgery patients. The room size is such that, you know, although everything's being miniaturized in medicine, one of the things that's not being miniaturized is all the ancillary equipment. And as complicated as some of the patients are, we need oftentimes more than 2 or 3 life-saving devices in a room. And with what we have currently, those rooms were never designed with that kind of need in mind. So the ability to provide higher quality care in a safe fashion is in a work environment that is better for the staff. We have also designed the space such that no nurse has to run, although it's big, no nurse has to move more than 10, 20 feet from the patient to be able to care for that patient. So we looked at workflow and where to station equipment and drugs and IVs so that the nurse's job is easier as well. And then finally, we've realized that patients do better when their family's involved in their care, and the ability for families to come here and be comfortable and be fresh, be able to have access to the family members, stay in the room, as you know, for a large portion of the day, I think is really important to us. Even just the fresh lighting. So a lot of people have the impression of St. John's as an old institution. It is. It has an old and glorious history. I mean, we've been doing open heart surgery here for 50 plus years.
Yeah, since the 60s.
But it's like a lot of, you watch those HGTV and you see the old home, and then you go inside and it's been renovated.
Yeah.
We're trying to give you that feel with fresh lighting, and patient and creature comfort.
How long have you and your team been planning this project?
Well, we got the go-ahead probably about 2 years ago, and we got handed a check for, I think it's probably in the order of $15 million, and then an entire design team got together with nurses, architects, construction, process improvement people, and we would meet literally every 2 weeks for months. Every single item, how a door opens. Does a door open this way? Does a door open this way? If it opens this way, how do we get equipment in and out of a room? Now I'm sure there'll be little details that we wish we had thought of, but minute details were planned out.
And this spring, there will be patients in this wing of the hospital, won't
Yes.
there? Will you need to have more staff, or will your present staff be able to handle it?
No, we have overhired, and we continue to hire. If there's anybody in the audience who wants to work in a brand new ICU and look after heart patients, feel free to contact us.
Would a heart patient now in this ICU, would his or her stay be shorter, possibly because of the new facility, or is there any way to gauge that?
Boy, that's a good question. I think their stay will be easier and seem shorter because it is possible. I mean, I think that we will be able to provide an even higher standard of care. Yeah, I do think that will be the case.
Well, it's obviously, you can see that it's not finished yet. The ceiling panels still have to be put in, but you can see, you can see the footprint, and you can see how it's going to make sense. And it's kind of neat to see it in this condition, because most people don't ever get to see it in the process like this. So congratulations, it looks like it's going to be a big success. Dr. Nandish, let's step away from the studio for a little bit and come to St. John's Hospital Cath Lab area. This is where many of the patients that go to the new ICU unit would come from, some from surgery, some from here. But this is also the place where many of your patients through the chest pain network, this might be their entry point to the hospital, I guess, in many cases, right?
You're right, yep.
What sort of instance would cause someone from an outlying area to come to St. John's Cath Lab?
So someone with chest pain can have a varied etiology, that means reasons for having a chest pain, right? So we created this chest pain network, which is an umbrella which catches everyone who comes in with chest pain. So someone may be walking there with chest pain just because their ribs are hurting. On the other hand, someone may be having a heart attack with chest pain. and that's the symptom of having a heart attack. So we created this network to catch all of these. But the goal is to make sure we pick them up right away, make sure that they are triaged immediately, and we pick up the sickest of the sickest patients, and we transfer them to St. John's Hospital so we can take care of them right away. So people may be like having a big heart attack, or it could be a small heart attack, but we want to get them here as quickly as possible.
Or it could be, like you say, it could be sore ribs, or it could be nothing at all, and then that would be figured out at the local
Exactly.
what, the hospital? The local
so the
hospital?
local hospital has a protocol, what we call as a chest pain network protocol. So when someone comes in, the first thing they do is to make sure, is this patient having a big heart attack or not? If that's the case, then they get him on the right medicine, give him the immediate necessary treatment, and ship him over by air or by ground, depending on how far they are. And that's the number one, that's the key, because time is muscle. So they have to get them up here. And when they get transferred, they come straight into this cath lab. And
Is that right? You have the capabilities here to take them like from where the helicopter lands right into the cath lab?
Right. So typically they come straight from the helicopter pad to the cath lab, and then we take them and we get them ready. In 10 minutes to 15 minutes, we have the artery open as soon as they get here.
So this replaces the old way of, say, a person's in, could it be Effingham, or could it be Litchfield, or a hospital like that, and they think this person's having a heart attack, and they put the person in the ambulance, and an hour later they arrive here, and in many cases they either have lost much of their heart muscle, or they could be dead by then.
Absolutely, yep. So the goal is to get the artery open and improve the blood flow to the muscle to save the muscle. So the triage is meant for it. And as I said, like, they could be having some rib pain, but we want to make sure that they're not having a major heart attack. If they are, we want to ship them here as soon as possible. So when they arrive here, the doctor's waiting here, the nursing team is waiting here, the technicians are waiting here. The whole team's ready to go take them and open up the artery. That's the goal.
Now, at the local, let's say at the outlying hospital where this person's having difficulty, how do they determine whether that person needs immediate care at the cath lab, or whether it's just something minor?
So when they come to the hospital, let's say they come to ER in Litchfield, as soon as they get to the hospital, they want to get, we want to, and they say they have chest pain or anything related to chest pain, like really bad shortness of breath, chest tightness, any of those. As soon as they get there with those symptoms, they get an EKG within 5 minutes. Once you look at the EKG, you could tell someone's having a full-blown heart attack or not. And if that's the case, they get him on good medications, and then they ship him over. They're calling the helicopter right then, and they get shipped out. Let's say if that's not the case, the EKG looks okay, but they're still having chest pain. That means they could still have a heart attack going on, but it's not a full-blown heart attack where the artery is completely blocked. So in that case, you have a little more time. So then they look at those, they do blood work, they do EKGs, and they see the blood work shows some damage, or they're concerned that their really symptoms sound like a heart pain. Then they call one of our cardiologists and transfer the patient. And now you have time, now they can be sent by ground. But they'll still get the necessary treatment initiated there, and then they send them up here. Once they get here, then we decide if someone's having an ongoing problem, we take them straight to the cath lab. But if they're all calmed down, settled, no chest pain anymore, then we have some time. Then we will usually get the heart catheterization done within 24 hours.
Now, for the sickest of the sick that come in the cath lab, oftentimes you have to use what I call it sort of a portable heart-lung machine, and you have what's called an ECMO, and then you also have an even more portable device, which is a tubing and a pump mechanism that you can carry from room to room.
Right.
Now, you're going to show us that one.
Yes.
But briefly describe the ECMO for us, so we know.
Someone with a heart attack or otherwise, if they're really sick, that means we are talking about somebody who cannot sustain their blood pressure on their own, cannot sustain their oxygenation on their own. If you can't supply oxygen to the body is going to fail. The organs are going to fail, and you cannot do much about it if you're way down the, what we call in that spiral. So you want to catch them early and take care of them. So you may be having someone being transferred with a heart attack, and they're having a blood pressure of 50. They're on blood pressure medicines, medications to support the blood pressure. But you can't keep up the blood pressure despite all the efforts you're making, and you're trying to open up the artery, and it's just like going down, you know. And in those situations, we can put these patients on this support called ECMO, which is extracorporeal membrane oxygenation. So what it is, basically, we'll go through that in a few minutes, but basically what we're doing is to support the heart and the lung to get the patient stable, get the oxygenation to the tissues, organs, the brain, and while that's going on, we can open up the heart arteries and take care of the patient. So this is definitely a life-saving situation, a life-saving mechanism to help support the patient. And in that way, we can do what's necessary for the heart to take care of it, and they have a good chance of recovering from it.
Okay, let's go back to the studio, and you've brought in one of these portable devices, and you can demonstrate that
Yes.
for us. Thank you. Okay, Dr. Nandish, now I'm looking at all these tubes and stuff, and I'm looking at a patient. So we called this patient the sickest of the sick. What would you attempt to do in this case?
So let's say in this situation, this patient has problems maintaining circulation. The biggest issue in a body is the need for oxygen. If the cells don't get oxygen, they're not going to survive, and organs fail. So the most important thing is to circulate the oxygen. For that, you need to have a good lung and you have to have a good heart. So in this situation, the heart's not pumping well and it's not oxygenating well because there's a lung problem as well. So in this situation, we put the patient on this, what we call a VA ECMO.
ECMO.
Right.
Does that stand for, is that
It's called extracorporeal membrane oxygenation.
Okay.
And what we do in this situation is, you see a catheter go all the way up to the heart in this blue line. And what it does is it draws the blood out of the heart from the right side of the heart. It goes through a pump called the tandem heart pump. And the heart pump, it's what we call a centrifugal pump. It just rotates and it pumps the blood back. And it goes through an oxygenator where the blood is oxygenated. And now the oxygenated blood is pumped back into the patient's body. And that's done through a small catheter put in the groin. And now you're basically pumping a oxygenated blood back into the circulation and let the body heal on its own. Once the heart and once the lung heals, then the need for outside support is going to be better and less, and then we can get the patient off of this support device.
So what you've done, Mark, is you've created a circuit outside of the patient's own heart and lung to take over the functions of the heart and lung to let them rest and recover.
Okay, doctor, as you show us how the rest of this device, isn't this like a heart and lung machine that they use in open heart surgery in the operating room?
It is, but this is kind of very portable.
Yeah,
And this can be, as you can see, this is a very small device. And this one we call as the heart pump. This is the main
That's the
centerpiece of everything.
That's the centrifugal pump.
It's a centrifugal pump. That's the main, it's like the heart, right? And this one is the blue tube. Basically, the one I showed you is hooked up to where we draw the blood out of the patient's heart through this catheter. And it goes back into the centrifugal pump, and the pump basically pumps it out into this other tube, the red tube, which is now, in cases where there is no need for oxygenation, then we just pump it back into the body through this catheter. If there is a need for oxygenation, in a lot of instances there is, so you hook up an oxygenator in between these two, and it gets oxygenated, and then it gets pumped back into the body. And that's going to be the key, because one, it's very simple to do it, and it's handy. That means if somebody is in the cath lab, they're in a dire situation, you could put them on it right away. Even if they're not, let's say somebody is not doing well and they've started chest compressions. While they're doing chest compressions, you can get this set up at the bedside. You can put the patient on this pump and support them and continue on until they recover.
Wow, fascinating.
If there is a concern that the heart muscle will not recover, this can be continued as what we call a destination to heart transplant.
Now, the demonstration we just saw would help maybe the people we might consider the sickest of the sick who report through the chest pain network to the cath lab. But Dr. Mischel, not everybody needs this kind of care.
Right.
And you don't know until you diagnose it.
So I think that this chest pain network, and again, I want to make sure that Dr. Nandish gets full credit for this, because he and Dr. Aguirre, hours and hours and hours, days and days and days, putting this protocol together. So it's really a recipe book of how to care for a heart patient from soup to nuts. And depending on your severity, you will go down a different path. So for instance, a patient might come into one of our outlying hospitals, part of the network, let's say Jacksonville, and they have chest pain, but it's not heart related, we determine. And so we'll say, based on our evaluation, our protocol, this patient doesn't have cardiac chest pain. You can deal with them there. Then the next step may be, yes, this is heart pain, but it's low risk and they can go home. And we'll set up a follow-up appointment, and that's done sort of automatically by protocol. The next step might be, yes, this is chest pain. It's a little higher risk than we would have liked to send you home the same day. You need to be admitted to your hospital, but you don't need immediate transfer, and we'll admit you to your local hospital, and you'll follow the protocol and contact us if things deteriorate. And then the final step, of course, is this is definitely heart-related, and you need to be transferred for more acute care, as we discussed with Dr. Nandish.
And Dr. Nandish, I cut you off earlier, but you said the outcomes have been really good.
Right.
What have you learned?
Well, the national door-to-balloon average time, that means as soon as the patient comes in through the emergency door and until you open up the heart blockage, there is a time frame where it has to be less than 90 minutes if possible. 120 is another number. The sooner you get it open, the better it is. When our patient hits the ER door at St. John's, our door-to-balloon times are very, very good in the 40-minute range. If patient gets into, let's say, Litchfield or let's say Effingham, even then our door-to-balloon time is really good. Like, we're within less than 90 minutes most of the time. If at the most, like, we can go a little bit few minutes later, more than that. And that's taking into consideration patient coming to an outlying hospital, getting triaged, getting transferred, coming to our cath lab, and getting this artery opened up. So I think time is muscle. So the sooner you can take care of it, the better it is. Since we have this nice system, very efficient system, and our competent physicians waiting for the patient, I think it makes such a good deal for the patient to get a better care in terms of getting their arteries opened up in a critically, in a timely fashion, I would say.
Just one quick teaser to add on to that. We're now adding on to that capacity by transferring the EKGs to the ambulance. And so now we can transmit directly between the ambulance, the EMT, the paramedics, the ambulance drivers, their EKG machine, and our emergency room. And in some instances where it's appropriate, we'll actually take the patient, say in Litchfield, from their home, bypass the Litchfield ER and come directly to St. John's to save even more time.
Based on the EKG that the cardiologist has seen in the home at the time the ambulance made the call?
Correct.
Right. Wow. Okay. And is that transmitted by smartphone, or how the heck does that?
By cell phone network. So the technology now is so reliable and so fast that you can, and the EKGs are so well displayed that you can transmit all of that information from the field.
Remarkable. And like Doctor said, time is muscle. So if you make it by 2 or 3 minutes, it could save a whole lot of damage to the heart.
Yes,
absolutely. One other thing I was going to say was, when someone gets a heart attack, it's not necessary that they are still stable, but they are very unstable. They could be having a blood pressure in the 50s and 40s, and by the time they get to the cath lab, they're really sick. And one other, thing what we have in our arsenal is this ECMO program, or the tandem heart we're going to be talking about, and that's going to be the key to stabilize the patient, open up the artery, and in that way they can do better. Otherwise, once they are in cardiogenic shock, we call, that means their heart stopped working and not working well, the risk of dying is extremely high. So this tool, this technology, what we have in the cath lab is really, really additional benefit.
Dr. Nandish, thanks. Appreciate it. Dr. Mischel, you too. Thank you for being here. And thank you for watching CARDIA, Hearts and Sciences. Remember, the heart, we all have one. The more we know about it, the better we can care for it. See you next time.
CARDIA is brought to you in part by H.D. Smith Foundation, a private grant-making foundation in Springfield, Illinois. Abraham Lincoln Capital Airport, daily flights to Chicago on United and to Dallas on American Airlines. Online at flyspi.com. Eck, Schaefer and Punk, LLP, and ESP Wealth Management, LLC, specializing in fulfilling all your accounting and wealth management needs. Securities offered through First Global Capital Corporation, member FINRA and SIPC. Investment advisory services offered through First Global Advisors Incorporated. Prairie Heart Institute, nationally recognized, locally committed. Online at prairieheart.com. And viewers like you, thank you.